This is one of a series of 8 films featuring some of the early pioneers of quality improvement in the NHS, who share their personal stories and the practical wisdom gained from leading improvement when it was still a niche activity. The idea for the films was originally conceived during a conversation between Peter Wilcock and Helen Bevan about capturing the legacy of early improvement leaders, and it was given life by the publication of the National Framework for Action on Improvement and Leadership Development. I've been privileged to have met all of the leaders featured in this series of films early on in my own improvement career, and so I found it fascinating hearing their reflections as they look back on their experiences. We hope that their stories will make a powerful contribution not only to those of you implementing the new national framework, but to everyone aspiring to improve healthcare. As you know, we're really keen to learn from some of the experiences of some of the early pioneers of quality improvement in the NHS. What got you involved in improvement work?
I was head of performance, head of NHS performance at what was then the NHS Executive, so that would have been about 98, 99. And at that time, there was the piece of work that started to develop the NHS plan. And I was involved in there were 6 modernisation action teams that worked on the development of the plan. I remember the first meeting we had, Don Berwick couldn't make the meeting, he couldn't make the date. And so he had sent it was a DVD then. No, not a DVD, it was a VHS tape. He had sent a VHS tape of one of his speeches at the forum. And it was the talk that Don gave called Escape Fire, which I actually think is probably one of his best. And I think it was just suddenly, so having worked with the NHS on performance and trying to get aspects of quality in, suddenly there was just somebody talking about it in this really different way, and not just the delivery style, although that was very different. I think more people talk like Don did now, but it was kind of a very new way of talking and presenting, and but it was just that thing of actually what can you do, and I suppose it made me think what a lot of my role was just about measuring performance, and what Don was talking about is what can you do about it. And so that was, it is a bit of a cliche, but that genuinely was, I think, quite a transformative moment. And anyway, and then subsequently after that, because I got interested in the sort of improvement stuff, and because Aidan had been on the team as well, and he talked a lot about the clinical governance support programme and how that worked. So I said, well, could I come and shadow a team through one of the programmes, the sort of, I think they're 12 months, sort of 4 residential things. So I shadowed a diabetes team from South Manchester through the programme. And I think that kind of just got me more and more interested in the, rather than just the sitting at the centre, kind of measuring things, how do you actually bring about change? And then obviously wherever I'd met Helen along the way, and she offered me a role at the Modernisation Agency.
So in 2001, you took up the role as National Director for the Pursuing Perfection Initiative, working with IHI and obviously with Helen Bevan. Can you tell us a little bit about what that initiative involved?
Pursuing Perfection was a programme that IHI were going to be running in the US with, I think, 7 healthcare systems in the US, funded by a foundation, Robert Wood Johnson Foundation in the US. And Helen was interested in the opportunity of supporting some UK-based sites to join the programme. And where it was different from what previous improvement efforts had been trying to do is, rather than taking a particular pathway or in a sense a particular quality issue of access, it was about trying to look at quality in a much more holistic way, and it was also trying to look about how do you work across the whole of the system, health and social care, to improve outcomes for patients. And I think it took a very strong sort of patient-centred approach to I mean, we didn't sort of have the language, I guess, then that we have now, but I suppose that sort of patient-defined outcomes, you know, asking what matters to patients, designing pathways around making it perfect for the patient. So it was very patient-centred. It took a very broad view of quality. It used a kind of quite aspirational framework of talking about no needless harm, no needless weights, no needless waste. So it was really trying to say, actually, let's not just improve to a target, let's kind of try and aim for perfect care.
What are some of the experiences during your time with Pursuing Perfection that really stood out for you?
I'd draw on three things, really. So the first was that it was very explicit in the kind of design of the programme, although that in itself isn't kind of the right terminology because it wasn't a formal programme, but it was very explicit that it was the work had to be led from the leaders of all the organisations involved. And there was a very strong sense of that the role of a chief executive isn't just to somehow manage the sort of operational, non-clinical aspects of care delivery. You know, the job of a chief executive was to create the right environment for high quality clinical care. And to do that, they had to understand clinical care in a way that I think some of the people we worked with perhaps hadn't previously seen their role. The second thing that I think, as I say, the sort of Pursuing Perfection framing of it, I think the second thing that it did that was quite different was really try to challenge the way in which we kind of normalise defects in care. And the thing that Pursuing Perfection did through the way in which it talked about no needless harm, no needless weights, was it was really challenging the idea that there should be any defects in the care that was provided. So I think that just created a different mindset to the way people approach the improvement. I think the third thing that came out for me was, I think it was where really a lot of the work on patient safety started in the UK. So what happened was we went, with the 4 sites that were participating, went to one of the learning events in Boston, and Brian Jarman was a fellow at IHI at the time, a senior fellow, and he was doing some work with his hospital mortality measure and looking at it for US hospitals compared to some of the costing data that they had. And what he'd been able to show was there was no relationship at all between the likelihood of you dying unnecessarily in a US hospital and essentially the kind of costs, the hospital costs, you know, how much they invested in delivering their care. There was no relationship. So you would be just as likely to have a really good outcome in a very low-cost hospital as a high-cost hospital, and vice versa. And the team saw him present there, and you know, we're kind of really interested. Again, at the time, there wasn't a great deal of focus on hospital mortality. And so when Brian came back to the UK, we said, would he run a workshop for us? I mean, one of the things that I really remember from that was Brian at the end of the day saying, this is the first time I've been asked to present the work I've done on hospital mortality to a UK audience. And that just seemed staggering. But anyway, that was the case.
What was some of the learning that emerged around leadership from Pursuing Perfection?
How some of the leaders of the organisations that were taking part started to redefine their roles as leaders. So we were working, I mean, actually all the systems that we worked with were selected because they were deemed to be already high-performing systems. And so they were people who were successful in their roles, they were doing a good job, you know, kind of as defined by the centre. And I think through the various sort of workshops and sort of coaching sessions that we had, where the emphasis was on encouraging them to think about what were their responsibilities to deliver high quality care, that created a shift in their sort of understanding and their view of what their role was. So from having been in a position where a lot of their focus was on managing finance and activity, and that's what they were assessed on, and they did well, they suddenly started to recognise that they had as much responsibility for creating the environment for delivering high quality care and the enabling environment for good clinical practice, as well as kind of managing the books. And I think for a number of the people that we worked with, and people who were quite advanced in their careers, that was really quite a shift in their perception of their role, and something that they kind of then really connected with, I think, as a motivator. So one of the sites that we worked with in North and East Devon, one of the priorities they worked on was around improving flow through the whole system. They would kind of have morning meetings to kind of look at what was happening with flow through the system every day, and they kind of really had a very effective approach. And so over time, flow improved, they were discharging more smoothly, and what they were managing to do was reduce medical outliers. And then I think there must have been, some external factors, wind pressure type things, or maybe there was some norovirus type outbreak. But something happened, and then some of the flow things broke down, and they ended up having more outliers. And what was interesting was that the operational manager who was responsible for that, she said, well, I suddenly started getting emails from some of the consultants saying, what's happening? This isn't right, we've got outliers. And the fact was that they'd just worked for years and years and years taking outliers as just a sort of, just something about the job, and the fact that they would have to be going around multiple wards to assess their patients each day. And then because they'd got the system working well, that just disappeared, and they suddenly saw what life was like without the problem, of having to manage outliers. And so I thought that was a really nice example of how people get so used to working in a certain way, they kind of stop seeing it, they don't define it as a problem, it's just what work is like. But then actually when you do get things working well, and then suddenly it flips back, people realise it doesn't have to be like that, and they were kind of onto it and wanting to fix it.
So what were some of your key lessons that you learnt from this work?
Because the Pursuing Perfection initiative was working across whole systems, it really illustrated the importance of working across organisational boundaries to improve the outcomes for patients and patient experience. And I think that still remains a challenge, because often it's a lot easier to just try and improve your bit, but then often you can just be kind of improving a bit of an imperfect pathway. And so that need for genuine collaboration along all points of people's journey through care, as well as the fact that actually what happens at the front line is highly dependent on the enabling environments. And then, then beyond that, even the sort of financing of the system, so one of the things we found with the work we did with North and East Devon was that, obviously if the system got better at reducing emergency admissions, the hospital lost money. And so one of the things they did as a whole system was come up with a way of essentially risk sharing, both the investment that was needed to reduce admissions, but also to share the benefits that came from that. And so I think that was kind of became very apparent about the sort of the need for whole system working. I think the other thing that struck me really is that I think improving systems is really hard work, and it's work that is you've got to be on it all the time. It's that thing of you don't kind of make something safe and then it's safe forever. You make it safe at every single encounter. It's constant. It's something that's always needs attention. And I think sometimes we perhaps don't really fully appreciate kind of just the attributes that people need to be able to kind of to keep that focus. And similarly, the relationships that are needed, I think, in particularly when we're doing whole system working across health economies, and the relationships that you need across organisational boundaries are so fundamental to getting good coordination of care. And and we just see all the time, the sort of constant changing, particularly in the commissioning structures, so that relationships and trust are established, and then structures get changed, people change, and once again all that trust needs to be rebuilt. So I think that seeing improvement in that kind of much broader context, I think, was probably some of the greatest learning.
In 2007, after 3 years at Calderdale and Huddersfield, you took a role as director at the Health Foundation and responsible for patient safety and person-centred care. What were some of the lessons that you learned from your early experiences that you brought to that role?
I think one of the things where perhaps quality improvement has not done itself any favours sometimes is that often it is presented as the answer to things, the answer to problems in quality and care, whereas really it's an answer. And it's an answer that's right in a particular context, and in other contexts, other methods, other approaches are more appropriate. So I think that kind of sense of really understanding where quality improvement is the right set of methods to be using, and where actually you might want to be using a different approach.
So Jo, what's been your key motivation throughout your improvement journey?
I think probably, not having a clinical background, obviously in a sense sometimes I don't feel I'm really an improver because I've never delivered a service to improve. But I think what I have recognised is the value to those people who are delivering services, whether clinically or managerial, but just to be able to have the support and the encouragement and the space and the sort of access to the ideas and also just the chance to kind of make sense of what they're doing with other people. Just creating that opportunity for people and seeing how much they value it, seeing how much it kind of keeps their motivation going, I suppose has been the thing that I feel kind of has made me feel most kind of privileged to do the job that I've been able to do.
What would be your advice to new leaders of improvement now?
Well, so 3 things really. So one, I think, recognise that all of this takes a long time. So when I just think through the kind of journey on patient safety, that's probably 12 years, 15 years, and it's still continuing, but it's a long, you're in for the long haul. And I suppose when I look back, I remember I used to go to meetings and people say, what do we need to do to kind of create an improvement system in the NHS? And then someone would say, and you can't say, put it into medical training because it just takes too long to happen. And I kind of think now, actually, if we had got it into medical training, we would actually have a medical workforce coming out of medical school with all these skills. I think the second thing is, there are no shortcuts to building the skills in the workforce, whether they're the technical skills around improvement techniques or whether it's the kind of relational skills around being effective leaders, being effective team workers. Those aren't, they're just, they're not innate. They're things that people need to be trained in, and that training takes time. And so if we want a high quality, reliable, person-centred care system, then we've got to invest in people's skills and capabilities. And I think the final thing I would say as well is that don't take anything as a given. I think for lots of reasons, I think it's very easy for people to think things are as they are because they've got to be like that, and I think there's a lot, that challenging those assumptions all the time. We've just got to start thinking differently about the way we deliver care.